Well, thank you, and hello, everyone. I want to first thank Orbis and CyberSight for bringing us all together. They do a marvelous job with education, and just looking at the registration, it's impressive the number of time zones that are represented here today. So I want to thank each of you for taking the time to participate. I'm Lou Cantor. I am the J.C. and Lucille Elkan Chair and Professor and Director of the Glaucoma Service at the Indiana University School of Medicine. I've also had the privilege the last several years to serve as the Senior Secretary for Education for the American Academy of Ophthalmology. Today, our topic is glaucoma surgery. Certainly an evolving art and science and a field that's been expanding greatly. We're going to discuss all facets of glaucoma surgery today. It's a broad topic. We have a lot to cover. So some of this I will go through somewhat quickly, and then we will be answering your questions at the end. We are due to conclude the webinar at 10 o'clock, but I'm certainly happy to remain on and answer any questions for any who might wish beyond that time for as much time as we need. So first of all, my disclosures here. I have research support, have served as a consultant for Zeiss and Santen, and have a small investment in a drug development company for drug delivery. I don't serve on any speakers bureaus for any of our industry partners. To start our talk on glaucoma, I wanted to start with glaucoma laser surgery. We often jump to just the incisional surgery aspects of glaucoma, but there's a lot to discuss with regard to laser surgery. More as a reminder about how effective laser can be if you have laser available to you. I'll go through this section rather quickly so we can focus on the incisional aspects of glaucoma surgery. But I think there's a few things that we need to sort of think about, remind ourselves about, and review. First of all, laser peripheral iridotomy. Angle closure is common in many areas of the world, much more common than perhaps in other areas, and certainly some areas of the world it's much more common than it is here in the United States. Laser iridotomy or iridectomy, the terms are often used interchangeably, has several indications: pupillary block, chronic angle closure, prophylaxis, and even in some cases where there's pigment dispersion syndrome, where there's reverse pupillary block as a mechanism that's pushing the peripheral iris posteriorly. There's certainly a number of contraindications to laser, not having a clear cornea, if the chamber is too flat or shallow, and if the angle is already closed with synechia, then an iridotomy may not be of much benefit and may actually be contraindicated. Just as a review, preoperatively, we often want to treat these patients before laser with something to lower the pressure a bit, maybe to constrict the pupil, certainly topical anesthesia. And we have different types of laser to consider. Some feel that the Argon laser may be a little bit more effective in brown irides, and the YAG laser for more lighter colored irides. But it depends on what you're comfortable with and what the specific eye looks like. And it's useful to have both modalities available for some patients where perhaps you might have difficulty with a YAG laser, an Argon or other laser may be effective. We often try to look for a part of the iris that's already thin, such as a crypt in the peripheral iris. There's been a lot of discussion about where to place these iridotomies. And that to avoid some of the light reflex and other issues that some patients may have. I still perform these superiorly between 11 and 1. You can do them temporally, you can do them nasally, but I've found that I have no lower incidence of patients being able to see a little light reflex if I put it superiorly as anywhere else. So I still like to keep the iridectomies superiorly between 11 and 1 o'clock, often just avoiding 12 o'clock in case there are bubbles during the treatment that might get in the way. We often use a lens such as the Abraham lens, which has this plano convex button on it to magnify and concentrate the laser energy and help with penetration. There are different settings that can be used for different aspects of laser. If doing an Argon, more thermal laser, if you want to just contract the iris, you use a fairly large spot size and longer duration with lower power settings. If we're trying to punch a hole through and create an opening, we go with a smaller spot size, shorter duration, and generally higher energy levels. Sometimes with Argon, it can take a lot of shots to get through. And this is a typical looking laser iridotomy done with the Argon laser. There's usually some surrounding atrophy of the iris from some of the thermal damage surrounding the iridotomy. With a YAG laser, our energy levels are usually anywhere between 3 to 10. We start lower and then increase the energy level as needed to obtain penetration. 1 or 2 pulses per burst is usually fine. I usually just use 1. And oftentimes, especially if we can find a good crypt, you can get through in very few shots and sometimes even 1. And then you do a few more shots just to sort of clean it up or enlarge it. And this is an appearance of a typical YAG laser opening. Now, any laser can have complications with blurred vision, maybe some monocular diplopia from a second image, glare. If the chamber is too shallow or we're out of focus, you can damage the cornea, you can cause a little bit of inflammation and some pigment dispersion. But most of these are generally short-lived and not of significant consequence. Here's a picture here that's showing where the cornea actually got suffered a thermal injury with an endothelial burn in that area. That may cause some focal opacity in that area, but generally doesn't expand and doesn't cause anything more extensive, so it's limited. You can get hemorrhage, pressure spikes, lens opacities, and what we worry about most often is closure of the iridotomy site over time. This is just an example of the typical type of bleeding we often get with a YAG. It's usually limited in self-seals. We get a little string or strand of blood that comes down and it stops. But I have had cases, particularly in patients on anticoagulants, where there was more extensive bleeding that actually formed a hyphema. Post-operatively, we want to make sure the pressures don't spike, use steroid drops, and we want to re-examine in 1 week. We want to look and see if our iridotomy is patent, but the most important thing to do post-operatively to make sure that an iridotomy has been effective is repeat the gonioscopy and see if the angle appearance has changed. The reason to do an iridotomy is not just to put a hole in the iris, it's to open the angle, which should be reflected on a different appearance on gonioscopy. So that's very critically important and often overlooked. People just look to see if the iridotomy is patent, but don't look back at the angle to see if it's actually functioning and if it's made a difference. For example, in a patient with plateau iris, you may put a hole in the iris, but the angle still remains occludable. So here's just a patient, referring a little bit to what I just talked about, who's had laser iridotomy for an acute angle closure attack, now comes in with painful, blurred right eye, vision's down, pressure's 45. What's going on in this patient? Already had a laser iridotomy for acute angle closure. What else do you want to look for? What's the diagnosis? What's the treatment in a patient like this? Well, if you repeat gonioscopy, you can see that there is still appositional closure of the angle, such as shown in this picture where there's the double hump sign. This is a plateau iris, a very frequently overlooked and misdiagnosed condition that's not appreciated. And the iridotomy does not relieve the angle closure in these cases because of the rotation of the ciliary body and that peripheral iris hump. The laser iridotomy only relieves pupillary block component that may be present, but not this peripheral hump. For that, we need to consider a different treatment, iridoplasty, which can be used in other conditions as well, but primarily is indicated in plateau iris. And there are contraindications to this as similar to any laser. We do similar preoperative assessment for iridoplasty. The laser parameters are a larger spot size, a longer duration, and low power. What we're trying to do here is constrict and shrink the peripheral iris and flatten that hump. And this is just a schematic showing that you place the laser applications, this with a thermal argon type laser peripherally. The number of spots can vary depending upon the effect, how much the iris constricts. When you do this, you treat them post-operatively and regonioscope. Again, complications can occur after any laser procedure, including iridoplasty. Most commonly, this is just a little bit of mild iritis that is short-lived. And here are some examples that show appositional angle closure on the left slide and in the middle, but after iridoplasty, the peripheral iris has been flattened out a bit and shrunk, and the angle has opened. This is another patient. This is a patient now, a long history, 73-year-old of primary open angle glaucoma. Pressures are somewhat high, borderline-ish, lots of medications, progressive visual field defects. What can be the next step? Well, laser trabeculoplasty is a good procedure in these patients before moving to standard incisional surgery if you have the laser available. Usually we're talking about maximum medical therapy or patients with poor compliance. Occasionally we consider laser even for initial therapy if patients are not good candidates for medical therapy and maybe don't have to have surgery right away. We often want to treat pressure preoperatively. These are some standard settings for the laser trabeculoplasty with the Argon laser, a 50 micron spot, 0.1 seconds, and then you vary the energy in order to achieve blanching and some occasional bubble formation in the angle. Usually I place about 50 spots over 180 degrees, but I usually treat 360, so therefore 100 spots throughout the angle. And you want to treat that anterior portion of the pigmented meshwork. We use a lens to do that so that we can effectively visualize the angle and the meshwork. And this is a typical appearance where we're aiming just at that anterior border of the pigmented meshwork with our aiming beam. We generally check these patients afterwards, treat them with steroids, and continue their glaucoma medications to see what the effect is. It generally takes about a month to know what the effect of laser trabeculoplasty has been. The effectiveness is about, in patients with standard primary open angle glaucoma, it's about 75 to 80% at a year, about 50% at best at 5 years. There is a failure rate of nearly 10% per year where the laser wears off. The pressure reduction depends a lot on the initial pressure. Patients with pressures in sort of the mid to upper 20s usually respond best. If the pressure is 30 or 40, you're not going to get where you probably want to be with just a laser. And the laser doesn't work well in our low tension glaucoma patients who are already starting at pressures of 16 or 17, for example, although it can be used and is safe in those eyes as well. It is good for phakic primary open angle glaucoma patients, patients with pseudoexfoliation and pigmentary. It's less effective in pseudophakic eyes, younger individuals, and other types of glaucoma. Even though laser trabeculoplasty can work well, for example, in pseudoexfoliation syndrome, pigmentary glaucoma, and in more heavily pigmented individuals of African descent, the effect is often a little bit shorter in those individuals and not as long-lasting. Again, the onset of effect takes a few weeks. 4 to 6 weeks is not uncommon. Maybe a little bit earlier for pseudoexfoliation and pigmentary, but again, maybe not as prolonged or persistent of an effect. And this is a typical time curve of the probability of success over time with laser. As we said, a certain percentage of these eyes are going to fail over time. And when it does fail, then we start to thinking, well, is it worth repeating? Well, generally with the Argon laser, a repeat laser is not as effective as the initial treatment. And if the initial treatment was not effective, a repeat is not going to be effective either. So it really depends. The patients who I consider for retreatment are those who responded well the first time and got several years of effect. And then maybe it's worth repeating the laser in those patients if need be, and we're trying to avoid surgery. Again, standard complications, the most common of which can be increased pressure, particularly with retreatment. You increase the risk of having pressure spikes, and not only of not lowering the pressure, but actually making the pressure worse. More recently, we've switched more to using the selective laser trabeculoplasty, the SLT laser, where that's available. Here's the parameters for that laser. It's a 532 laser nanosecond pulse. Probably the biggest thing that we notice about this laser is its spot size, a 400 micron spot size compared to the 50 micron spot of the Argon laser. This actually makes the treatment with SLT much easier because it's difficult to miss the target. So here's just a schematic showing on the left the typical size of a 50 micron Argon laser spot and the 400 micron spot of the SLT laser, which basically blankets the entire angle, so it will be hard to miss the meshwork with the SLT laser. Whereas if you're a little bit off with the ALT, you can actually be treating in the wrong place and not getting the effect that you want. SLT and ALT in this study, looking at repeat lasers, equally effective. So there's no advantage in efficacy with a primary laser, or if there's been a previous ALT to doing an SLT, it still works well. This is the typical histology of ALT, which does cause thermal effect, as shown in the picture on your left with that cratering and coagulative necrosis in the angle. It actually causes a small focal burn, whereas the SLT, being that the laser energy is just absorbed by the melanosomes within the trabecular meshwork cells, doesn't cause that sort of thermal effect if delivered appropriately. It doesn't change the architecture of the angle. And here's just one study from archives in 2003 looking at using SLT as even primary treatment. You get the typical 4 to 5 millimeter drop in pressure that we expect with laser trabeculoplasty in general. Now, in our treatment algorithm, there's lots of rethinking of the sequence of where we do things and how we do things and where surgery fits in. For the majority of patients, at least in the US, we're going to start with medical therapy, and the majority of the time that's going to be with a prostaglandin analog. Hopefully we're controlled with medical therapy or maybe combination therapy. But at some point, we move to laser and then start thinking about surgery. And where surgery fits in is also evolving, as we'll talk about more towards the end here, with some of the newer procedures that are being introduced today. So let's talk about incisional surgery for glaucoma. Our gold standard remains trabeculectomy. There's a lot of excitement over alternative procedures today, and that's wonderful, and I think there's great promise there. But still, when we need good pressure lowering and effective long-term control, and where we have long-term data, it remains trabeculectomy, this guarded partial thickness filtering surgery, where we create a fistula between the anterior chamber and the subconjunctival space. We typically think of indications for trabeculectomy as when the pressure can't be maintained otherwise. Now that's going to vary in different parts of the world depending upon what's available. In some areas I know that medical therapy is difficult to obtain or maintain chronically. Laser may or may not be available. So how we define when to move to surgery really depends on availability, depends on a lot of patient factors as well. How likely is a patient going to be able to follow up? How reliable are they? What's the social structure around them? There's a lot of things that fall into this. Excuse me. But generally, for us in the US, we're talking about maximum tolerated medical therapy, which again is variable. How many drops is that? Patients who have failed laser, but basically it's in patients who are progressing or who are likely to progress because of optic nerve damage if we don't get their pressure lower. There are relative contraindications, of course, to any procedure, and certainly trabeculectomy has these, blind eyes, eyes with neoplasms, rubiotic eyes with neovascularization, active inflammation, injury, extremely thin sclera. I do see patients with very thin, almost blue sclera who are not going to be able to be helped by this type of approach. The techniques vary. We all have our own techniques. So this is where the art, it's an evolving art, and there's a lot of different ways to perform a surgery. When we talk about trabeculectomy, we're not talking about a single monolithic procedure that we all do the same. The conjunctival flap can be Limbus or fornix-based, depending upon what you're comfortable with and how you learned it. The use of anti-fibrotic agents, mitomycin and 5-FU, varies. How you make the flap, how you create the sclerostomy. Do you perform an iridotomy or not? How do you close the scleral flap? Do you suture it tight or suture it loosely and allow for leakage? What sort of conjunctival wound closure is used also varies quite a bit. I'm just going to cover some of these steps and some of the options, and many of you may do these or other things as well. There's no way to cover every possible aspect and alternative to how to approach this. In Limbus-based versus fornix-based, if a Limbus-based flap, which actually I prefer a Limbus-based flap in general, I believe that I get better results myself. You try to make that the conjunctival incision as far posterior to the limbus and the fornix as you can, generally at least 8 to 10 millimeters. For fornix-based procedures, obviously we're making the incision at the limbus. How much of the limbus you open and how wide you make that is, again, a personal preference depending upon your technique. Each approach has advantages and disadvantages, again, depending upon what you're comfortable with. It is important to note that if you look at studies, the success rates are the same, the IOP outcomes are the same, regardless of how you do it with your technique. In general, the Limbus-based conjunctival flap is a little bit more challenging to do. It takes a little bit longer to close. The fornix-based flaps are easier. How you use a traction suture is different between the two the two flaps. Whether you use a superior rectus traction suture, which we often need for a Limbus-based flap, you can do a corneal traction suture for fornix-based. There's more leakage likely at the anterior edge of the flap if you're doing a fornix-based flap with a limbal incision. Placing the mitomycin differs a little bit, where the scarring occurs. And the final bleb appearance does vary a little bit depending upon how you make your incision. And so just this very initial part of the procedure, there's a lot of nuances to and a lot to consider. In terms of anti-fibrotic agents, the ability to attempt to modulate wound healing is really critical and has changed the face of trabeculectomy quite a bit. Before we had the availability and evidence that these agents were helpful, our failure rates were higher. And it's now unusual, extremely unusual almost, to do a trabeculectomy without some anti-fibrotic usage to try to modulate wound healing. Most often here in the US, it's mitomycin. 5-FU can also work as well in certain circumstances, but mitomycin seems to be a little bit more effective for the majority of patients. There's a lot of indications for it, but as I said today, if you ask people in an audience of glaucoma specialists here in the US, how often do you routinely use mitomycin in your glaucoma surgery cases for trabeculectomy? virtually every hand in the room goes up. And I've been in rooms where that question has been asked, and it's rare to see someone's hand not up. So it's become very routine. Now, should you do it in every case? Well, you do have to be cautious in some patients. And for example, one place where you want to be cautious is in the young myope, because they are particularly prone to hypotony maculopathy. Very elderly patients with extremely thin conjunctiva may be another case where perhaps it's safer to avoid the use of the anti-metabolite, and because the success rate would be probably pretty reasonable anyway. So there are exceptions, but they seem to be relatively few today, and we're using these agents very, very routinely. Just as a review, 5-FU is what we call a pyrimidine analog. It really inhibits, excuse me, it inhibits fibroblast proliferation. These are the typical doses that are given. You can apply this with a sponge underneath the conjunctiva or by injection. The advantage is you can titrate a little bit. The disadvantage is you often need multiple injections to make it effective. Mitomycin is an alkylating agent, and it actually kills cells. So as opposed to 5-FU, which just stops cells from dividing, mitomycin is cidal. It actually kills cells. There's a lot of different concentrations. There's no standard agreed upon way to administer this drug. Again, it depends a lot on your personal technique, what you're comfortable with, how you do your surgery. It's hard to isolate any one step in glaucoma surgery and say, if you do this, your outcomes are going to improve, because the whole surgery is a symphony. And just changing one measure in the middle doesn't necessarily change the entire symphony of what you're doing with this procedure. Typically for me, for my standard patients, I'm going to do 0.2 milligrams per cc concentration for 2 minutes. That's sort of my starting point. If someone has a lot of risk factors for failure, then I'll go up on the concentration to 0.4. If someone has a very low risk for failure, or someone I want to be conservative with, then maybe I'll shorten the time and only leave it on for a minute. But these are all individual decisions that are made with whatever experience you have with these medications based on your technique. You can also deliver this by subtenon's injection as well, and avoid just the intraoperative application. So it's a one-time for this. You avoid the multiple injections, but we are relying on these sponges or now some injections, and it's rather imprecise where it's going and how we do it. Remember, sponges are not drug delivery devices. They're soaking up devices, so they're not really designed to deliver drug, and they don't necessarily always do so in a controlled manner. So we can cut shields in half, we can cut sponges, we can stick a whole sponge under there. Very effective to use. How you do the scleral flap? In general, I try to make the scleral flap about 1/2 to 2/3 scleral thickness, but what's really important is how easily is it going to leak around it based on your sclerostomy that's underneath. So how big you make your sclerostomy and the relationship of that to the scleral flap is what really matters, because that's what determines leakage. It's not the shape of the flap, whether it's triangular or a trapezoid, rectangle, whatever you want. The size of it doesn't necessarily matter that much, as long as it's big enough to leak. That's what you want, and it's the relationship to the underlying sclerotomy that determines that, and wound healing. And how you make your sclerostomy, it's really for the most part more of a keratectomy. We're usually just removing peripheral cornea to create the sclerostomy, and trying to be anterior so that we don't get into the ciliary body, reduce bleeding. In some areas, the express shunt is used as opposed to making a scleral flap to allow for that sclerostomy to be created. And these are just some pictures of inserting the mini glaucoma shunt in a case rather than making a sclerostomy. various studies have been done. This is just one. Using the Express to create the sclerostomy versus using a punch or a blade and scissors to create the sclerostomy doesn't really affect outcome. So there's no advantage necessarily to the Express. It's just, again, if this is something that you like in your technique, that's fine. It is an additional expense, and on the cost side and cost effectiveness of surgery, there's some debate here, but the outcomes are the same whether you use an Express or something else. If you do an iridectomy, if you do your surgery, is an iridectomy important? I like to perform an iridectomy because I've had too many cases where I've had an iris, if I didn't do an iridectomy, find its way into the sclerotomy and obstruct it internally. Also reduces pupillary block from potentially happening in the future if there's synechia that develop around the pupil, for example. You do have to avoid the ciliary processes, avoid the zonules and the hyaloid face, so you don't want to reach down too deep, but an iridectomy is a standard part of what I typically do. And I typically create the sclerostomy with a blade and with scissors rather than with a punch, but again, it's however you are comfortable and what technique makes sense and works for you. The scleral flap closure can affect outcomes as well. How many sutures and how tight you want it, and whether or not you do releasable sutures or plan on suture lysis. Personally, I put in only usually a couple sutures on my flap and leave them rather loose, as I like the sclerostomy to be leaking at the end of surgery, as I would like for it to long term. In order to avoid shallowing or a flat chamber, I leave some viscoelastic in the eye, however. So that usually buys me time for things to start healing. If you don't have viscoelastic available or that's not part of your technique, then you may need to suture the flap a little bit tighter, but plan to have less filtration and higher pressures in a deeper chamber, but then you may have to release those sutures either by cutting them or lasering them or releasing them if they're releasable sutures. Lots of ways to handle just the scleral flap closure. And then finally, the conjunctival closure. There's a lot of different ways to do this. If you performed a Limbus-based flap with a fornix incision, then I typically, which is what I do, I typically close conjunctiva and tenons separately with a running suture, absorbable suture like Vicryl. For a fornix-based flap being closed at the limbus, usually there's wing sutures placed on the sides with then some central suturing to closure it. There's different ways to do that. There's a technique of a running closure called a Condon-Weiss technique, and other closures for closing at the limbus. This just shows closing in the fornix with a Limbus-based conjunctival flap. You can see the trabeculectomy here underneath this, and we're fairly far back here. This isn't stretched out, but we're probably at least 10 to 12 millimeters back from the limbus. And this is showing with a limbal incision with a fornix-based flap, and we're starting our closure here, and then we'll wing it at both ends and run a suture anteriorly to try to minimize the leakage. That's that Condon-Weiss technique. What I always tell patients when we do glaucoma surgery, virtually any type really, but certainly for trabeculectomy and tube shunts, which we'll talk about in a minute, is that the success of the surgery, half of that success depends on what we just did in the operating room. The rest of it depends on what we do post-operatively to achieve success, and how we handle these eyes and how we manipulate them. There's a lot of post-operative care required. And maybe it's releasing sutures, maybe there's massage, maybe we need to supplement with some antimetabolite. Suture lysis can be attempted with various lasers and various lenses. Hoskin lens, Blumenthal, you can use a Zeisconium lens, and Argon laser works well for this to help cut sutures if you need to increase flow. It's also important that we understand for both short and long term how to manage filtering blebs. We developed a grading scale we called IBAGS, the Indiana Bleb Appearance Grading Scale, which is represented here, which looks at what I think are the key characteristics of a filtering bleb. Its height, its horizontal extent along the limbus in terms of clock hours, how avascular the bleb is versus vascularized, and whether or not there's any leakage of a bleb. And leakage, we can have no leak, we can have no streaming leak, but a lot of blebs kind of sweat and they get these little pinpoint leaks as shown down here, or we can actually have a full positive sidel with a streaming bleb leak. There's lots of complications early and late that can occur after glaucoma surgery. And it's important to understand your complications. And if there's one chart, I always tell our residents to make sure and memorize it's this one. So if you have a shallow or flat chamber, which when you first post-operatively in the early post-operative period, the next thing you look at is the bleb. Is it high or is it low? The next thing you want to look at is what's the pressure. Is it high or is it low? If you have a low bleb with low pressure, then you already know what you're looking for. There's either a leak, choroidal effusion, or some overfiltration with a leak. If you've got a low bleb but high pressure, you're looking at aqueous misdirection or pupillary block. You've got your diagnosis and your treatment's going to follow from that. If you have a flat or shallow chamber with a high bleb, if it's low pressure, then you're overfiltering. If it's high pressure, chances are you need to take a good look in the back because you've got a suprachoroidal hemorrhage. So just understanding and the differential of a shallow or flat anterior chamber based on the bleb and the pressure really leads you to diagnoses and then subsequent treatment very quickly so that you can manage these patients effectively post-operatively. For a bleb leak, whether it's buttonholes from surgery or thin avascular blebs, these are problems that we often have to deal with in our standard filtering surgery. There's lots of ways to manage these eyes, pressure patches, aqueous suppressants. Usually I do lubrication and try to get these patients off steroids quickly, and hopefully they'll close on their own. If not, then we may need to manage it differently. There can be glue, there's other ways of handling a leaking bleb, compression sutures, lots of different techniques, and I don't have time to really go into, but we have a lot of options at our disposal. This is just one example of an eye where we did an autologous blood injection. We just took a few tenths of a cc of blood out from the back of the hand from a vein, and then we went up with a 30 gauge needle and injected it into the bleb as is shown in the upper left picture. And then here's the resolution of the blood over time and the final bleb, and the pressure came up, the hypotony resolved just by causing a little bit of fibrosis within the bleb by a blood injection. Here's glue on the eye, which I've sort of stopped doing because it's so uncomfortable. Because if you put glue over a leaking bleb, you have to cover with a contact lens and then wait for the glue to fall off. And so I've largely abandoned this technique. It's also important to separate what do you mean by shallow or flat chamber. If there's just iridocorneal touch in the periphery, most of those eyes are going to reform spontaneously if you observe them, maybe add some atropine and pupillary dilation. But if there's corneal lenticular touch or corneal IOL touch, then the cornea can decompensate. You can get anterior synechia. If there's a lens in the eye, it can cause cataract. So those eyes really need more urgent management. There's lots of ways to reform a chamber. Most often what I do is viscoelastic, but you can inject air, BSS, other fluid. And you also have to look for choroidal effusions to see if there's drainage that might be indicated. The effusions occur from hypotony and inflammation. They're generally not there right away. They take a few days to develop, unless it's something like a hemorrhage. But just choroidal serous effusions usually occur 3 to 5 days post-operatively. They start occurring if you have persistent hypotony, especially with inflammation. And this is an example of what a choroidal looks like and some of the signs and symptoms. can occur after any surgery. Certainly if there's a choroidal hemangioma, if you're dealing in a patient of Sturge-Weber, nanophthalmus, or increased episcleral venous pressure for any reason, then an effusion risk is increased. These we can typically observe and they'll go away with steroids and cycloplegia, but we may need to treat. We may need to drain if the chamber stays shallow, they're long choroidals, you've been there a long time, they're not going away. Then we may need to consider drainage of choroidal effusions, which I do occasionally. Hypotony maculopathy is another issue, again, particularly in our younger myopes, particularly younger male myopes, seem to be more predisposed. And here's a good example of those choroidal folds that you can see in these patients. You have time to manage this. Generally, these choroidal folds are reversible if the hypotony is treated within 6 months. Most times within 12 months, even the choroidal folds will resolve and go away. But the longer they're there, the more likelihood that they can become fixed and permanent folds that affect vision. Suprachoroidal hemorrhage is, of course, something we all worry about and want to avoid. It occurs in the first 4 to 5 days. Generally after surgery, there's a lot of risk factors. Glaucoma being a big risk factor, and we're doing glaucoma surgery, but advanced age, vascular disease, aphakia, myopia, previous vitrectomy, and so forth are all risk factors. We manage these similar to effusions, and if there is clot, as is shown in the picture in the suprachoroidal space, you can't really drain it right away because it's clotted. And clot lysis takes 4 to 5 days to start. It may take 10 to 14 days for that entire clot to become liquefied. But sometimes we do have to drain these if there's severe intractable pain, uncontrolled pressure, persistent flat chamber, or other reasons. Failed blebs we can deal with in many ways, but what I want to encourage you to do is if the bleb starts to appear to be failing, do gonioscopy and look at the internal sclerostomy. We often miss the fact that there's been a fibrin membrane or some scar tissue or iris that's affecting the internal sclerotomy when we're trying to treat the bleb on the outside of the eye, but not treating the actual site of the problem. Late bleb failure from episcleral fibrosis is also something that we have to be on the look for. And it's the most common reason why filtering blebs fail. And blebs can become encapsulated, but most of these will resolve. This is the typical tenon cyst. And we can manage these usually conservatively. Rarely do they need surgery. And lastly, just bleb-associated infections we all have to be on the lookout for and warn patients about, particularly in thin avascular blebs. We need to treat lid disease if patients have blepharitis, and tell patients that if they develop a red eye or conjunctivitis, even if it doesn't seem concerning, they should always let us know. And here's a couple examples. These are the risk factors for bleb-associated infections. Most of these are preceded by a bleb leak, but we don't always see that right away. And these are some of the common organisms, but that can vary where you are in the world. This is what they look like. Here's various examples. They are often leakage. I sort of grade these. Stage 1 would be where it's just a localized bleb infection with not a lot of spread internally. Stage 2 is where we're having some anterior chamber reaction. And stage 3 is where there's a hypopia and vitreous involvement and a full endophthalmitis. Stage 1 and 2 we can often treat with aggressive antibiotic therapy. Stage 3 will usually require vitrectomy or at least a tap and inject of intravitreal antibiotics to try to save the eye. The incidence of bleb-associated infections is not insignificant. There's been several studies that have looked at this. In general, I tell patients that over their lifetime, they have again, depending upon age, if it's a 50-year-old who's getting a bleb, that's very different than an 80-year-old, but there is a risk of having this happen. And I tell patients about the issue of developing a red eye, and our patients know well to call us if they start to develop anything that might be a sign of a bleb leak or bleb infection. We usually can manage these with antibiotics, as I said, topically initially. And again, stage 3 requires more aggressive management for endophthalmitis. Now, to mention tube shunts here, tube shunts are great alternatives when standard surgery has failed, or for other eyes where you expect a trabeculectomy to fail, such as a uveitic eye or an eye syndrome, for example. We have multiple types of tube shunts. Non-valved, such as Maltino and Barvelt, are the most common here in the U.S. Valved, the most common is the Ahmed, which is also available here in the U.S. But there may be other types of shunts available throughout the world. They all do about the same thing. One of the important factors with these shunts is what is the implant size? What is the area for filtration? And there's been several studies that look at this, and actually around 250 square millimeter area is about the maximum that a single quadrant device can effectively work and lower pressure. I don't use the Barbell 350 for that reason, because you really don't get additional pressure reduction from that larger size versus the 250. And the other valves are somewhat smaller, so you don't get as much on average either. So for me, the Barbell 250 has sort of become the standard tube shunt, and I use the others, such as an Ahmed, if I'm trying to be more conservative in someone with risk factors for such as a suprachoroidal hemorrhage. Lots of ways to implant these devices. And the key factors, though, are to get the device itself, the plate, well posterior in the equatorial or post-equatorial region of the eye. Too many times I see these shunts put in and they're too anterior, and they work less well, and they are more prone to erosion and exposure if left too anterior. Multiple steps to the surgery. Again, these are a little bit more standardized perhaps than trabeculectomy, but there are still a number of steps. One of the decisions is, especially for the wider devices such as a Barbell 250, should you make an attempt to push it under the muscles? Can it be on top? Can it be intratenons? The answer is all of that is yes, and they all work the same. Just depends on what your technique is and what you're comfortable with. Typical medications post-op, if you tie off the tube or occlude it somehow, or if it's a valve shunt, you may need to use something for pressure post-operatively initially, and then always be on the lookout for hypotony. These do have some benefits. They're less prone, if a patient's a contact lens wearer, they can wear them. And they do work well, but they don't work quite as well as perhaps long-term. There's a study that was done, the trab versus tube shunt study, which showed similar long-term results, but initially trabeculectomy seems to work better than a tube shunt. So it depends on what your goal is for pressure. This is also looking at trabeculectomy versus tube shunt and failures. There seemed to be a little bit higher proportion of failures in the trabeculectomy group over time, but when you took those out, then again, the results were similar. And here's looking at different pressure goals from those studies. A lot of postoperative complications still possible from all of these procedures, including tube shunts. Now, just for the last couple of minutes here, there's been a lot in terms of new glaucoma surgeries and the MIGS procedures. This is the current, probably most common definition for a MIGS procedure, these micro-incisional procedures that have a high safety profile, minimal tissue manipulation, and so forth. There's been lots of ways to divide up the different types of MIGS. This is just one example from Steve Vold. Part of this is trying to take advantage of the outflow pathway, and particularly the canal-based procedures to really recover and use the canal, the collector channels, and the episcleral venous plexus, and to really get at where the site of resistance is. But there's a variety of devices. So we have a variety of canal-based MIGS procedures, devices and non-device procedures that cover either a small area of the canal, such as a micro bypass shunt, where it's just a very focal, to 360-degree viscodilation and trabeculotomy type procedures where you open up the entire trabecular meshwork to try to allow fluid access to the canal. We are still sorting out how these various procedures work, but they are becoming a more common part of our glaucoma therapy. There are attempts at suprachoroidal based MIGS procedures to drain into the suprachoroidal space. CyPass and iStent is under development, and there's Translimbal MIGS. I might mention that the CyPass in the US was recently withdrawn from the market because of issues regarding endothelial cell loss concerns. And then Translimbal based MIGS that are clear corneal procedures. The Zen is the most common here in the US. There's also the in-focus microstent, which is still in clinical trials, which offer different approaches to translimbal based MIGS. And then of course there's a variety of cyclodestructive procedures which can be considered MIGS type procedures, whether it's done by endocyclophotocoagulation or transscleral. I mentioned canaloplasty. Well, it's not a MIGS procedure. It's an older procedure that I really liked and got good results with, but we're doing it less with the newer procedures. But what it did highlight was how you can alter the anatomy. So if you look at Schlemm's canal preoperatively here on the left, and then look at it on the right, you can actually see dilation of the canal and even perhaps dilation of collector channels on this high resolution ultrasound, really showing how we could impact the outflow system with some of these procedures. And we can likely do the same thing with some of our MIGS procedures. And here's a good example showing pre and post canaloplasty, how you can open up the canal. So here's our trabecular stents. Trabectome I don't use much anymore, but opens up a few clock hours of the canal. Again, the suprachoroidal stents, CyPass, and the iStent Supra. There's been studies on these. Again, this is the data that caused the voluntary withdrawal of the CyPass just a few months ago here in the US because of cell loss, where if you look here, the blue bar is the CyPass compared to control. These were in eyes that had phaco plus iPass or phaco alone. Trials underway with the Supra. And here's some of the subconjunctival or translimbal stents as represented in these pictures. Various pros and cons to each of these. What I think is important for us, and I'm going to show this very quickly here because the details I wanted to show you in the graph, but if you look at review studies, and we're starting to get more and more data on all these various procedures, and here's the procedures that were looked at in the study. And what I want to show is this graph. So this graph shows if you, and the individual procedures, I know there's a lot here, but these are all compared to the clinical trials, of which there were reasonable numbers that had some sort of comparative control group. And the line down the middle would be if the addition of the MIGS device, if it was to the right or versus the left in terms of how much more effective it was. So if you look at iStent, say in the second group down, the improvement over phaco alone, or medical therapy here, and here's phaco alone, is about 2 millimeters of improvement. And the closer these bars are to the center line, the less effect. To the left, and to the right actually suggested higher pressures. So what we're seeing with the MIGS procedures, that we start to get devices that, yeah, they can lower pressure, but it appears to be not only minimally invasive, but for many of these procedures, the effect is also fairly small, but they're very safe. So you're usually looking at 2 to 4 millimeters maybe of improvement in some of these procedures, but not much more than that. So trabeculectomy still remains our most effective procedure, and just some more data on that. And I want to get to the end so we can take your questions. But if you look at trabeculectomy in the 21st century, it's really quite an effective procedure. again, compared to Express, we get in many of our patients good sustained long-term control, low teens to even single digits in multiple studies. And as things start to filter out over time, I think we're getting a dose response curve on our various procedures. So at the bottom here is phaco alone and what it does. Above that, with the addition of laser, then we get into some of our MIGS procedures here in terms of percent pressures. But at the top still remains trabeculectomy and tube shunt for when we really need good sustained long-term pressure reduction. So the algorithm may be changing, but it hasn't completely changed yet until we get more effective MIGS procedures. So with that, I thank you for your attention, and we'll now turn it over so that we can get to your questions.
Great, thank you, Dr. Cantor. If you want to stop sharing your screen, you can bring up your Q&A questions. So far, there's 2 questions.
Okay. So in phacomorphic, first question is, in phacomorphic glaucoma with no light perception, raised pressure, would you rather perform argon laser iridoplasty when patients refuse to have cataract surgery? Well, I'll answer that question in a couple ways. First of all, if the eye is truly NLP and there's no chance of any visual recovery, I would try to avoid surgery. There's really only 2 reasons to treat the pressure in glaucoma, and that's to prevent pain and preserve vision. So from a vision standpoint, there's no reason to treat if the eye is NLP. Now, from a pain standpoint, if the eye is uncomfortable, usually we can control these eyes medically. And even with minimal medicines. Sometimes it may be reasonable to consider a laser, but I would avoid an incisional surgery in an eye that's NLP myself. And the second question is, I think as a follow-up, how about cyclopentolate drops to maintain the anterior chamber post-operatively? Absolutely, I think that's certainly reasonable. A lot of these eyes with end-stage phacomorphic or other types of glaucoma with uncontrolled pressure, if you can just put them on a cycloplegic, cyclopentolate, atropine works well, maybe a steroid, maybe an aqueous suppressant like Timol, that's all you have to do. So generally in those eyes, less is more. The next question is do you believe there's a place for MIGS procedures in the developing world as a replacement to trabeculectomy? Great question. I think MIGS procedures have an increasing role in what we're doing, but they are not to the point yet where we can replace trabeculectomy, in my opinion, for the vast majority of people that have glaucoma. What the MIGS procedures, I think, are allowing is, if you want to think of it, generally our treatment for glaucoma has been a one-size-fits-all. You put a hole in the eye or you don't. You know, trabeculectomy, a tube shunt, or you don't. Where the MIGS procedures are more aimed is for the mild to moderate end of the spectrum. So I think that in the patient with mild glaucoma, even if they're in the developing world, if there were a MIGS option, it may be something to consider for those patients so that we can preserve the trabeculectomy for if they get worse or if they fail the less invasive procedure. But for the majority of patients who have more moderate to advanced disease, the MIGS procedures are not going to probably reduce their risk of blindness right now, and we need to probably get to a trabeculectomy or a procedure that's going to control them. So it's an evolving area. I think our MIGS procedures are going to continue to improve and be more effective as well. The next question is, do you trim tenons to avoid encapsulated blebs? I do not. I do not do a tenonectomy in conjunction with filtering surgery, either trabeculectomy or tube shunts. I've tried it a few times and haven't found it to be effective. Other authors have tried it, and there was some reports that it actually wasn't very effective either. I think the increased tissue manipulation with tenonectomy can just lead to more reactive fibrosis. Next question is, what guides your choice of anesthesia? For me personally, I still, for the majority of surgeries that I do, which are fairly involved and often are in eyes that have had previous surgery, I primarily do blocks, and usually retrobulbar or peribulbar blocks, oftentimes combined with a facial nerve block as well. I do sort of a modified O'Brien by the ear as a facial nerve block, so that I have good control. I like to have full control of the eye, and I like to have really good exposure of the eye. So I most often use blocks. Can you do a lot of the less invasive procedures and MIGS and things with subtenons or topical anesthesia? Yes, but those aren't the patients that I see and get referred to me most often. Next patient question, I should say. What would you recommend for a patient with plateau iris angle closure who has had iridoplasty and persistent IOP rise despite medications? Yeah, well, with plateau iris, presuming that we've done the peripheral iridectomy, which is always the first step, plateau iris is really defined as an angle that remains occludable despite a patent iridectomy. But then if you've done the iridectomy and you've done iridoplasty, and it may just be that there's enough either synechial closure or there's been enough damage to the meshwork from the previous angle closure episodes that medications can't control it. And so then I think you have to go on to surgery. And in most cases, probably a trabeculectomy. If anyone, there's no open questions posted right now. If anyone else has a question, I'm happy to address it. Here we go. How long does hypotony last until it causes maculopathy after trabeculectomy? The hypotony maculopathy develops very quickly, actually. I mean, it can develop in the first few days with hypotony. So it doesn't take long for it to occur. What's interesting about the hypotony maculopathy is that once the hypotony resolves, either on its own or because you've intervened in some way, for the hypotony to reverse seems to take about as long as it was there. So if the hypotony was there a month, let's say, before the hypotony resolved and it caused maculopathy during that month, it may take a month for things to straighten out. If the hypotony had been there for a year before the hypotony was treated and reversed, you may have to wait a year to see if it's going to go away, even once you get the pressure up to a normal range. What key words to use to convince patients to have surgery? Yeah, well, first of all, I don't try to convince patients to have surgery. I try to advise them as to what I think is in their best interest and give them the options that are available to them. And it ultimately is the patient's decision. One of the things that I frequently do, especially for patients who are concerned about the risks of surgery, because there are risks, and we always talk about that. And patients often get in their mind that they have a high risk of going blind from the surgery, which there certainly is a risk. I tell patients you can lose your vision from surgery, But the other side of that equation is without surgery, the likelihood of you losing your vision is 100%, let's say. Because if the pressure is uncontrolled and the glaucoma is getting worse, your vision will go, but although maybe more slowly. So we do have that discussion, and you know, it's how you phrase things, but ultimately it's providing the patient with the information you can and the perspective and what you recommend, but it's their decision. Now there was a question about how to manage hypotony maculopathy. There's various ways to manage the maculopathy. Generally, it's from an overfiltering bleb. And usually, first of all, after surgery, if there's some hypotony and a little maculopathy and it's in the first few weeks or month or even 2 after surgery, I don't do anything. Because most of the time, just with normal wound healing, the pressure will come up. If the bleb looks really big early on, I may taper off my steroids a little more quickly. But if the hypotony doesn't resolve and someone has maculopathy, it depends on the appearance of the bleb. Number one, if there's a bleb leak, you need to fix it. Most of the time, there's not a leak. It's just a large bleb that's too big. And there's a couple of ways that I've found most effective personally, but there's a lot of different ways to manage bleb, some of which we talked about during the presentation. One way is just to revise the bleb and do a conjunctival advancement flap over the bleb. If it's very thin, very avascular, you can mobilize conjunctiva around the bleb and deepithelialize the bleb and pull the conjunctiva down over it and do that. There's other procedures where I make incisions through the bleb and suture it down. Some people, kind of like a compression suture, but I actually make an incision if a bleb is very extensive. Let's say the bleb is covering, you know, 6 clock hours, it's so extensive. I will go up at between 11 and 1 o'clock and make incisions through the bleb and then suture it down with an absorbable suture to create a barrier to shrink the bleb. Those are just a couple ways that you can manage an overfiltering bleb that's leading to hypotony maculopathy. What IOP values do you consider as optimal first day post-op is the next question. It depends on, again, it depends on how you do your surgery. I typically expect my patients after trabeculectomy, for example, to have a low pressure post-operatively because I do not suture the flap tightly, but I leave a high molecular weight viscoelastic in the anterior chamber, usually Helon GV or something similar, Helon 5 even, a very viscous, to maintain the chamber and create, and we get these very nice blebs, and then it takes a few days for that viscoelastic to wash out of the eye. And the pressure is usually pretty low during that time, but at least the eye's having a chance to start healing, and some of the medications from preoperatively are starting to wear off and the ciliary body is starting to function. However, if you like to suture your flap more tightly, you know, then you're probably aiming for pressures, you know, early on to be in the 10 to 15 range. But I find that very hard to control. So then you have to be willing to manipulate sutures. What is the dosage and duration of steroid eye drops we should use after trabeculectomy? Yeah, this depends on the patient, but in a standard glaucoma patient without a lot of inflammation, where the surgery went fairly straightforward, I will usually use just prednisolone 1% 4 times a day. If the conjunctiva was very injected, you know, then we may bump that up to 6 times a day. But normally for the garden variety patient, I'll use 4 times a day prednisolone 1%. In patients who have a history of any uveitis or iritis, we will certainly bump that up to every couple hours, and I'll often give, at the time of surgery, a subtenon steroid injection as well, even just some dexamethasone, where I don't expect it to last a long time, but I want to get a lot of steroid on board very quickly. And some of those patients with history of iritis, I'll often put on oral steroids also. But the average patient not inflamed, terribly, just 4 times a day is usually fine. And the last question is, do you have any therapy for neovascular glaucoma? Yeah, neovascular glaucoma is tough because it's not only the glaucoma, it's the underlying disease that you have to treat, whether that's from diabetes or from vascular disease, a vein occlusion or some other condition. You need the retinal treatment is a mainstay of treating any patient with neovascularization. So they need to get that treatment, whether, we will often give an anti-VEGF injection and try to get in laser right away. But for the glaucoma part, we almost routinely will go just directly to a tube shunt procedure, and typically either an Ahmed or Barval tube shunt.
Great, thank you, Dr. Cantor.
Thank you very much, and it's those are wonderful questions. Thank you, everyone, and hope this was useful.